Dr. Anthony Papa. He did his graduate training in grief, trauma, and resilience at Teachers College in New York City, and did his postdoctoral work at the National Center for PTSD in Boston, helping to develop online interventions for grief and trauma. Prior to coming to UH Manoa, he continued to do research and publish on diagnosing and treating pathological responses to grief and factors related to resilience after adverse life events. At the University of Nevada, Reno, which he continues today as a faculty member here in the Clinical Psychology Ph.D. program at UH Manoa. So it's a real treat and a pleasure to welcome Dr. Papa for his talk today. So thank you very much, Tony. I'm going to turn it over to you.
Thanks, Brian. And thanks, everybody, for having me. Let me just share my screen here. Can everybody see the screen?
Looks great.
Okay. So today I'm going to talk about what to do for youth after some kind of disaster or mass trauma. And this is really just an overview of the grief and psychological trauma treatment literature. Today I'm going to be talking about the decision-making process and determining when to intervene for individuals who've experienced bereavement. Talk a little bit about psychological first aid and skills for psychological recovery, just a basic overview, a stepped approach to interventions, and then just kind of talk a little bit about the difference between normal experiences of grief and in the aftermath of trauma and how you differentiate that from pathological responses and when to intervene. I will say that we're going to be talking about trauma, so in potentially traumatic events. So if you find this triggering or causing stress, feel free to sign off, and feel free to turn off your camera. It's just fine. So diving into the content, we have a little bit of time. I want to start just by talking about diagnostic issues. But before I do, I wanted to just make this one point that by far and away, most people are resilient in the aftermath of adverse life events. If you look at how many people experience what we call pathological or prolonged grief disorder, it's only, depending on the study, somewhere between 3 to 10% of the total population, usually on the lower end of that. And if you think about exposure to traumatic events in the U.S., about half the population in the United States will be exposed to a potentially traumatic event, but only 6 to 8% will go on to develop post-traumatic stress disorder. Research has shown that there have been 4 pathways that have been found in longitudinal research following people over time to see kind of how they've adjusted in the aftermath of adverse life events. And as you can see down in the bottom right corner, there's people who have this bad reaction and they continue to have pathological responses. Those who have kind of an acute response with recovery immediately following. There are a few that have delayed, and by far most people have resilient. This is true even in the context of natural disasters and large-scale events such as, say, Hurricane Katrina, where about 66% of mothers exposed to Hurricane Katrina exhibited resilience over time. It's in youth during the same hurricane, in the Wenchen earthquake. In the course of this research, particularly focusing on youth and children, it seems that a large majority of kids also exhibit resilience over the course of time, though there has been some research recently that came out of this, that there may be this kind of low chronic thing that happens with kids, where in the aftermath, they have kind of subclinical symptoms that last. And it's unclear at this point whether or not they resolve over time, though there are some initial indications that they do. Also, before we kind of get into diagnostic issues, I just want to talk a little bit about what's normal grief. We talk a lot about psychopathology here, and of course, given that we're focused on intervening, we kind of sometimes can lose the forest for the trees. But what is normal grief? And I will say that normal grief reactions are really different individual from individual, and they can range from really having no response at all, or maybe just transient in the days afterwards, to pretty serious kind of disruption that could last several months. In terms of how long a normal response is, I have to say that there is some controversy about that. The longitudinal research that's out there suggests that most people recover within 4 to 6 months if they're going to recover. And that's from the longitudinal research. The DSM committee, in their diagnostic criteria for prolonged grief disorder, has specified a year. And there have been previous folks that have said 2 years. And again, the concern here is that folks aren't being pathologized for normal grief reactions. The only problem is that, if somebody's recovering within 4 to 6 months and there's a range, and we're not able to diagnose and tell a year, there's a potential that people suffer needlessly over time. So with this, I would recommend that folks take this with a grain of salt, the 1-year time frame. Now, in terms of what is prolonged grief disorder, you can see that this is the DSM criteria. It involves the loss of a loved one in the last year. It involves intense yearning and longing or preoccupations with memories of the deceased person. And then as a result of that, displaying things like identity disruption, disbelief about the death, avoidance. You can read through the symptoms there. And again, with all DSM diagnoses, it has to cause clinical significant distress, has to exceed kind of normal, expected social cultural norms, and they're not better explained by something else. And so this is the current kind of explanation or criteria for prolonged grief disorder at this time. It's been around for about 20 years, even though it's been just recently put in the DSM-5. There's a fair amount of really good research to suggest that this is different than major depressive disorder and post-traumatic stress disorder, even though there tends to be a lot of comorbidity between this and those two diagnoses. Now, but of course, we're talking about youth. And of course, a lot of these diagnostic categories that you see in the DSM don't apply to kids. But there's research on, what research does exist, and it is fairly limited, I will say, on prolonged grief disorder in children and adolescents suggests that in studies ranging from 7 years old up until 23, the prolonged grief disorder symptoms seem to be the same in kids as they are in adults, with one caveat, that in smaller kids, some of the cognitive kind of displays of the criteria are modified, given less cognitive complexity in smaller kids. And in kids, these are also distinguishable from depression and PTSD as well. We also talk a little bit about what's normative for potentially traumatic events after experiencing a traumatic event. And as with grief, they can range from really having no reaction at all to pretty intense emotional reactions that look exactly like the DSM-4 or 5 criteria. And I must say that the PTSD criteria in many ways indexes a normal response to adverse life events. The 30-day criteria that distinguishes health from not health is really an actuarial line. That people who, after 30 days of continuously showing these symptoms, have not gotten better, that they're not likely to, but there may be some variation in the individuals that you work with. This is important because as we're going to talk about a little bit later, that pathologizing normative responses, particularly in the early aftermath of traumatic events, can be harmful. So I just want to make that point early, and we'll revisit it later as we get going here. Now, in looking at potentially traumatic responses to potentially traumatic events in kids, the PTSD criteria are a little bit different or displayed a little bit different in children than they are in adults. With kids, it can be a criterion stressor can be defined as learning that's happened to a parent or caregiving figure. In terms of intrusion symptoms, you can see it in play reenactment or being overly bright. In terms of avoidance, rather than kind of overt avoidance, sometimes it's displayed in such socially withdrawn behavior or constricted play. And you can read through, especially in terms of arousal activity, smaller kids can be just irritable and throw temper tantrums instead. So it is a little bit different when you look at kids versus adults in PTSD. And it is as well when you look at diagnostic criteria for major depressive disorder. As you read through the kind of different kind of levels of display or ways that kids would meet criteria for major depressive disorder based on age range, you can see that it really follows a developmental arc where kids who are younger, because of their lack of ability to understand the world in complex cognitive ways, tend to show disruption in terms of play, acting out in destructive kind of behavior, as opposed to, as they get older, become increasingly more cognitively complex and look more and more like adults. Now, other kinds of reactions, though, that aren't prolonged grief, PTSD, or major depressive disorder for kids and youth in general include separation anxiety, uh, acting in overly dependent ways on caretakers, including kind of excess need for reassurance, being clingy, excess proximity seeking, not wanting to leave parent or caretaker's side. But it can also look like perfectionism or engaging in controlling behavior. Small kids who don't always have control over their environment can control then the attention that they get from their caretakers in these ways as a ways to establish safety, and is something to look for. You can also see it in, say, morbid fantasies or questions, things like, are we going to die? You know, is there going to be an explosion? Are we going to die? Mom and dad, are you going to die? It can look at things like compulsive behavior, shyness, unexpected shyness, or social uncertainty, but the list really goes on and on. But these are the more likely things that you might see in the aftermath that might not necessarily be diagnostic in nature. There are also a host of other things that, as a clinician, you might want to pay attention to. Sleep problems has been strongly associated with subsequent adjustment in the aftermath of grief and trauma, and it's also a key symptom in major depressive disorder. In terms of points of intervention early in the aftermath of events, things like CBTI or CBT for insomnia might be something that you might consider early on, given that its effect on subsequent adjustment in the severity of diagnosis later. In terms of other kind of responses that folks might have, and this is kind of more relevant for adolescents and adults, but substance abuse increases, poor health behaviors increases in terms of not eating well, social disengagement, decreases in activities of daily living, especially in adolescence. But one of the more important things that folks need to be aware of is that there's a sharp spike in suicidality in the aftermath of traumatic life events and the loss of loved ones generally. You have all the comorbidities that I've just talked about related to anxiety, depression. There is significant sleep disruption. There's loss of meaningful engagement with what might have been primary sources of reinforcement, which all contribute to a sense of hopelessness, helplessness, which increase then subsequent suicidal ideation. In the case of mass traumas and in death, there's also other considerations. In the current theories of why folks or how folks become suicidal, two of the key features are that people perceive that they're a burden on others and that they acquire the capacity to be able to act out on any suicidal ideation or plans that they might have. Now, in terms of burdenness, you know, especially for folks who are displaced, you know, certainly that's a consideration. But even if you're talking about, say, the loss of a loved one, and I'm disrupted in turning to my peer group, I mean, certainly I'm an emotional burden on all of them. So it kind of creates a situation in these cases where burdensomeness could be perceived very easily, or at least be predisposing. Now, in terms of acquired capacity, depending on how somebody might have lost somebody, or if there was death involved, or they were exposed to death, if there was suicide in the aftermath of one of the survivors and there were friends of those, they all contribute to people's ability to say, maybe I can do that too. So if you're considering some kind of evaluation of these diagnostic categories, certainly one might consider prioritizing suicidality right up at the front. Other issues such as guilt and shame of what was done, what I did, what I didn't do, what I could have said, what I didn't say, also contribute to the possibility of increased suicidality in survivors of grief and trauma, and certainly should be considered, as well as anything that is associated with increased impulsivity, like substance abuse, emotional dysregulation, being older or younger. And this is particularly salient for older, elderly folks, sleep deprivation, or anything that characteristics of the individual that's associated with impulsivity would be a concern in conjunction with experiencing these events. So it would be something that you might consider. Other responses, I know the list goes on and on, but that that you might want to consider in evaluating folks who've experienced grief and trauma are the cognitive consequences of experiencing these events. A lot of things that people would display in the aftermath of adverse life events include problems reconciling the reality of their experiences, actions or reactions to the event. Was I weak? Was I dysregulated? Do I have shame and guilt? Did I do something that I'm not proud of? Does it create moral injury? And also that it might be related to the events not kind of fitting into existing worldviews. This is how the world was, this is how the world should be, and then this thing happened to me. If you're familiar with just world literature, the shadows assumptions literature, this is what we're talking about here, where folks' assumptions about the way the world works have now been violated, and it means that then the world can be an unsafe place from this point forward. Now, in these cases where people are having trouble reconciling the reality of their experiences and what they've done and or beliefs about the way the world should be, it often comes with disengagement from social environments, and then, of course, disengagement from sources of positive social reinforcement, which means then individuals typically then get kind of stuck with and sitting alone with kind of negative aversives in their day-to-day life, which leads people to feel more and more negative and focusing more on shame and deprivation, leading to helplessness and hopelessness. And again, this is a feeder then for increased suicidality later. Now, what I've talked about up until this point have been fairly general kind of other things that might happen in response to trauma or loss. But in terms of what might affect the intensity of reactions to loss and trauma for kids, certainly things like exposure to the potentially traumatic event, either in themselves, their family, or friends, if they've lost a caretaker or a close family member, or another child at school that they knew, or in their class, increases in family conflict, and lower levels of family functioning, cohesion as a result of the events. So say in the case of, say, Lahaina, after being displaced or something along that line, disruption at home during cascading secondary stressors due to fires or whatever the event might be, meaning I've lost my livelihood, I've lost my community, I've lost contact with the folks, the aunts, the uncles, the people in my day-to-day life that give life their daily social rhythm, and now gone. I can't do that anymore. Things like financial strain, food security, all of these influence family functioning, which again can in turn affect how kids adjust to the events themselves. Another thing that influences kids' reactions to loss and trauma is whether they get excessive or inadequate information about what's happened. I guess this is scaled based on level of development, how much information that they get. But even for really small kids, not being told what's happening and why things are happening can create anxiety. Other things that you might consider are whether or not the events, the stress from the events are adding to or having synergy with any existing problems that kids might have had by making them worse. Whether or not the losses or the experience of the trauma are similar to other situations that they might have experienced, so situational similarities, but also state similarities. I'm feeling exactly like I did when this happened. These can often be a strong trigger for unresolved trauma and should be something that you consider when you're looking at long-term adjustment. And of course, for kids, loss of key social supports when coping with any of the things that I've talked about so far. This is particularly relevant in the aftermath of large-scale disasters. Research on large-scale disasters is called the social support resilience deterrence model, suggests that communities disrupted after a disaster follow a specific pattern where there's initial kind of coming together of communities, both internally and then support from the outside. And as time goes on and people become more focused on the day-to-day needs as a result of the disruption of experiencing these events, the community cohesion tends to dissolve over time, which means then that folks are left really without the supports that they might have had or initially said that they had at the beginning of the events when it seems like it's most acute. And actually, sometimes the support dissolves over time when it's not as acute. Other issues, of course, might be things like self-blame, and the list really goes on and on and on and on. But I would say that in the context of thinking about all of these different things and how they might affect the adjustment of youth or really anybody in the aftermath of these disasters, it's really you're looking at the combination of the direct exposure, any kind of chronic exposure to reminders of the consequences of the events, and any of the ongoing secondary kind of stressors that exist because of the events. And to the degree that they feed kind of a sense of uncertainty, if they're associated with any perception of human intention or neglect, either in the cause or the exacerbation of my current situations, you would want to know about them and address them earlier rather than later, as you're considering what to do with folks in your evaluations. Other things that affect kind of adjustment after a disaster in youth can be, of course, I've already mentioned the reciprocated relationship between parents and family dysfunction, age. Younger kids have a more difficult time than older kids at times, though it's not always the case, but according to the research. And of course, any economic disadvantage of the self and the community also contribute to poor adjustment over time. So those are all the kind of diagnostic issues, or at least evaluation issues to consider as you kind of decide what to do. But then, of course, the question then becomes, what do you do? So before I kind of dive into that, I just want to start by saying that one of the things that we've done as a society for quite some time has been psychological debriefing. And that could be critical incident stress debriefing, critical incident stress management, or all different kinds of psychological debriefing. Now, outside of the specific groups that these interventions were initially designed for, which were military and police, these things typically don't work. So what is psychological debriefing? So psychological debriefing is asking people to describe what's happened to them, getting a group together, sitting them in the room, and then going around the room and asking each person, what's happened to you? Tell me your thoughts, interpretations of what was happening to you as it occurred to you. What were your emotional reactions and behavioral actions during the event, and any symptoms you've experienced since that time before walking into this room. So as somebody who would lead, say, a psychological debriefing kind of session, I would go around the room and just ask each person individually to share their story and make sure they included these details. These things are then discussed by the group and normalized. And the idea behind psychological debriefing is that people can hear that other folks are experiencing the same thing that you are and normalize their experiences and hopefully reduce them over time. I would then provide some kind of education about the transient nature of the symptoms and the immediate aftermath of these events, and then give folks kind of a general idea of, when might you seek care if things aren't getting better. Now, it sounds like a really great idea. And if you look at the research literature on psychological debriefing, folks tend to perceive, the folks that have engaged in psychological debriefing, that they tend to perceive that it's useful. But across multiple reviews, across multiple domains, age groups, and folks that are not police or military, so we're talking civilian populations, CISD, CISM, or psychological debriefing has been found to be ineffective and does not prevent any subsequent psychopathology. And in many of the studies, they've been shown to exacerbate subsequent symptoms, meaning that folks that engaged in the psychological debriefing ended up worse than folks that didn't. As to why, the current thinking about why this has occurred has been that in sitting in a room in the immediate aftermath of experiencing a traumatic event in which I am dysregulated and barely have my feet on the ground, and sitting in a room of, say, 10 other people, and then having to listen to everyone else in the same room tell me about their experiences, the event that I'm having trouble dealing with right now, can be overbearing. And it makes it so they can't cope, and essentially becomes overwhelming at that point. And in fact, subsequent research since this time has shown that really any universal intervention of any kind are a bad idea in the aftermath of adverse life events. So what I mean by a universal intervention is something where you're offering a program to somebody just because they experienced the event, not because they're showing any particular symptom, okay? Consistently across studies, across different kinds of interventions, universal intervention or different kind of modalities of interventions have been shown to not work and not work very well. The only time that kind of immediate intervention in the aftermath of an adverse life event has been shown to be useful has been when there has been adequate screening to show that people have significant psychological problems that need to be addressed in the moment. In other words, just because I experienced loss doesn't mean I need to be in the grief group. Just because I experienced trauma doesn't mean that I need to be in any kind of debriefing group. Okay. But it does lead to this question of then what to do in the immediate aftermath. Certainly, we don't want to just say, oh, the research says we can't do anything, we shouldn't do anything. And of course, this is why psychological first aid has been developed. So psychological first aid is a program that I know folks have been familiar with here in Hawaii in the aftermath of Lahaina. I know we've had training through HPA in this. I'm just going to talk about it briefly today and then talk about skills for psychological recovery later in a little more detail. But how and why psychological first aid might be indicated in the aftermath of events in terms of what you might do is that it differs from psychological debriefing in that traumatic events are not reviewed. Psychological briefing is really kind of geared to just simply providing people access to resources that they might need in the moment in order to cope with where they are in the moments. Okay. It also involves some kind of screenings where you'd be sitting with people and saying, okay, tell me what's going on. And then any kind of screening to see if they're suicidal, if they're experiencing a severe depressive episode, et cetera, that might involve some kind of immediate care. But for the most part, this is really just helping people get the resources they need to cope. Psychological first aid can be considered maybe the first step of a step care approach to responding to these kinds of events. And if people are interested in learning more about it, there's some really great resources at the National Child Traumatic Stress Network at this website. And I'll be glad to make these slides available for people if anybody wants these links. But just as an overview, the goals are to promote a sense of safety, calm people, promote a sense of self and community efficacy, promote a sense of connectedness, and instill hope in the immediate aftermath so they can get back on their feet and move on to what they need to do. In terms of the formal steps involved in psychological first aid, they include contacting and engaging the individual, providing safety and comfort to the degree you're able, maybe some stabilization, information gathering about what the person might need in the immediate aftermath, any kind of practical assistance that you could offer in the moment, you would offer it. And that could include connection with social support, any kind of coping information, or linkage with any kind of collaborative services available in the aftermath of these events. Now, just going through these really quickly, contact and engagement is really just sitting with somebody being non-directive and being supportive, engaging in active listening, not making assumptions, and just trying to hear what they need to say in the moment. In providing safety and comfort, your goals are really just to enhance immediate and ongoing safety, provide any physical, emotional comfort. So, if you need to not be here right now because it's not safe, direct them where they need to go. If you're cold, you're hungry, if there's anything that we can do for you in the moment, this is what we're focusing on doing now. Note what we're not doing right now is we're not focusing on how you're feeling. We're not trying to restructure any of their thoughts. We're not trying to focus them away from the emotions they're having in the moment. We're just trying to meet their needs in the moment. In the next step, where we're looking at evaluating people, one of the things to be clear about is that we can't, during these times as we're providing safety and comfort, and we are in the kind of the initial stages of this engagement, that any of the reactions that people are displaying are necessarily pathological, despite how extreme they are, unless they're specific symptoms of, say, major depressive disorder or a major depressive episode, excuse me, or something like suicidality that might need immediate intervention. In providing safety and comfort, your goals are also to look at things like how might I protect the person from additional exposure to trauma or any reminders of the trauma, and any kind of social engagement or connection with social resources that might help them in this moment feel better about what's happening or kind of regulate their emotions in the time. This could include kind of meeting any kind of psychological needs by answering questions like things like what to do next, what's being done to assist folks right now, what we know about the events, what we know about what's going to happen next, and here are the common reactions that people might have. Later, when you're looking at kind of what to do in the aftermath of events, and it's been a period of time, safety and comfort, focus on safety and comfort could include things like ensuring that the return to school feels safe and that they return to familiar environments and routines the best possible given the events themselves. There are folks who require stabilization, though for the most part, most people won't. But stabilization is really just helping people focus on what their immediate needs are right now if they're overwhelmed by the emotion that they're having. So it's things like acknowledging that this is really stressful, talking about what they're doing to cope, providing them reassurance that they're doing a good job, doing anything you can reduce the stress that they're experiencing in the moment, which could be breathing retraining, it could be focusing on my voice, or tell me, about yourself and tell me about your family. But again, I just want to emphasize again that these reactions are not symptoms and shouldn't be treated as such. It's just helping people kind of get their feet back on the ground so they can focus on what they need to do. Okay. Now, one of the key things that's important for psychological first aid is, again, we're providing support, but it's really just information gathering as well. I'm assessing the needs of survivors, providing them what I can. But again, I'm also looking for any kind of risk that might entail them needing services sooner than later, directing them to what they might need. Okay. Helping them identify problems they can't handle. And again, built in and baked into the psychological first aid protocols is paying particular attention to the needs of children, young people, and other groups that are particularly vulnerable, and in their caretakers who are then responsible for trying to meet these needs and helping them meet those needs as they go. Now, in terms of things you might ask, this is kind of a long list of things you might ask that include things like, what's going on? Do you have concerns about what's going to happen to you? Are you concerned about safety of loved ones? You have guilt and shame. Have you thoughts about causing self or harm or for not preventing harm to other people? And so on and so forth. But one of the things that we often ask are things like, tell me about what happened to you, the nature and severity of their experiences during the event, or tell me about who you lost. And again, this would be something that may be relevant, but it also may be something that you might want to tread very carefully with, because it opens this can of worms that for us as providers who've been trained to address these issues directly might pull for us to start saying, okay, well, tell me how that feels. So careful as you move through these stages and get to this point. Again, ultimately, we're looking to provide people practical assistance in psychological first aid, which is identifying the most immediate needs, clarifying what that need might be, discussing an action plan, and defining how you might act to address that need in very specific, concrete ways. And again, in very simplistic ways, because people are feeling overwhelmed. We're not doing anything complex, burdensome, or complicated. Here's the one thing that would help you the most right now. We're focusing on that. In providing and working with folks during this time, one of the things that we know that the folks who have the best outcomes in the aftermath of experiencing traumatic life events or adverse life events in general are folks who can maintain a sense of optimism, maintain a sense that life is predictable despite what happened here today, believe that things will work out in some way or another, that that there are people looking out for me, and that they'll be here for me in case I need it. Folks who have really strong faith-based beliefs often do better in the aftermath of adverse life events. They're not always, especially if there's some sense that this is a judgment of God, then they tend to do worse, but that's rare. And any kind of positive beliefs that people might experience or might be telling you doing these things would all be things that you might try to reinforce as you're discussing anything with folks during these time periods. Okay. In terms of then, one of the primary and most important things you can do is connecting people with social supports. Now, this could be family members, but it could be church groups, it could be the Red Cross, it could be anyone. But to the degree that you can help people get a hold of the folks that are most important to them would be the most helpful during this process. However, a thing to kind of focus on here is that when people in the immediate aftermath events, and this is in the hours and the days aftermath in the hours and the days after, they often tend to be very self-focused and overwhelmed by their own reactions. So in providing these supports or trying to link them also supports or providing them any kind of help, it must be something you keep in mind is that anything you can provide can be overwhelming. I'm just focused on today. I'm just trying to get to the next moment. And you want me to do what? You want me to talk to whom? I don't think so. So careful with that. You can also provide coping information, anything that would help people feel a sense of control and what can be controlled in the situation would be helpful. Okay. Any kind of engagement in goal-oriented or purposeful behavior, anything that provides any sort of meaning can be helpful in feeling a sense of in control over the events and what my subsequent um, reactions might be. In this and providing kind of coping information, it's important to discourage negative coping ways of coping. Help them maybe consider different ways they've been coping, other ways they might cope, how have they coped well in the past, what are their personal strengths. Talk to them about, where you want to be, what do you need right now, how are we going to get you to that in really concrete ways so that they can help promote their sense of control in the moments. It can involve things like teaching relaxation techniques. It can involve helping families try to have some routine of any kind in the course of the events. It could be things like anger management, dealing with guilt and shame, talking about sleep problems, addressing any alcohol and substance use. But again, in providing any of these kind of coping information or coping assistance, again, overwhelming folks in the aftermath of these events is certainly something you should consider. This might be something that could wait for later. And of course, finally, the last step in psychological first aid is then providing people linkage to any services available, provided by state and local governments or community organizations that are available to folks. Now, in terms of programming or having programming in place for dealing with the aftermath of, say, large-scale events that involve trauma and grief, certainly psychological first aid is a good first part of a step care approach. Again, in any step care approach, the first thing you want to do is kind of normalize reactions, let people know that there's no right way to grieve or respond to negative events, that everybody responds differently, and that even if I'm having a really strong reaction and other people aren't, it's okay. That's just normal too. And of course, these are all the things that psychological first aid as a program, as a structure provide. So if you're thinking about developing kind of a step care program for folks who've experienced that or in preparation for these events happening in the future, certainly training in psychological first aid would be ideal in a lot of ways. I will say, though, just specific notes about grief, though. In providing psychoeducation about grief, it's important to know a couple things that have come out of the grief research literature over the last several years. One is that there's a basic assumption in our society that in order for people to resolve grief, they have to work through their grief or do their grief work. And what I mean by that is confronting the events, kind of feeling the feelings, going through the feelings, and then over time, if you express these feelings fully and allow yourself to feel them, that you'll get better. These ideas are based on an old Freudian idea that if people need to fully experience and fully engage in their emotions so they can decathect or detach from these lost objects or these lost people. But the grief work literature, in examining this over time, has really found no evidence that grief work is necessary. In actuality, some of the programming, kind of the early intervention, primary universal interventions that I talked about were really focused on facilitating grief work early in the process in order to help people resolve their grief right away and get better. And really, it's in almost all cases backfired, either was not helpful or iatrogenic. So at this day, I can say that there's only been one study that I've ever seen that supported that needing to confront feelings might be helpful. But again, this is only one study in a series of several dozen. So again, if doing grief work is something that you consider integral to doing grief therapy, I would say that there is a time and place for it for some people, but it's certainly not something that everybody needs to do. I also want to just kind of talk a little bit about, in providing psychoeducation, one of the things that folks often do is ask, provide self-help books or, answer questions about what's a self-help book or what's an online resources. As somebody who studies grief, I like in looking at many of the self-help books that are out there or online resources that are out there for grief in particular, most of them focus on working through emotions or the stages of grief models. Now, stages of grief models are really just kind of, these are the steps that you need to do in order to do your grief work and resolve your grief. Research on stages of grief have found that there are no stages that anybody needs to go through in any particular order to resolve grief. While many of these grief models, these stage models or step models of grief identify things that many people who are bereaved do, it doesn't mean that anybody has to do them. And actually forcing people to go through these steps often can be problematic down the line. Now, the problem with these self-help books, because they're based on this, is what they're often prescribing is the proper way to grieve in order to get better, which means then that folks who, are not having strong reactions or not having those reactions often come and say, well, I'm not doing that. What's wrong with me? And it can undermine people's ability to cope in the moment because they feel like they're somehow lacking in some way. If you look at resources, self-help books and resources for people who are at risk for post-traumatic stress disorder, there are some pretty good resources out there, including, I'd mentioned already, the National Child Traumatic Stress Network, the National Centers for PTSD, all have great resources for folks who've experienced adverse life events. And there are several good self-help books out there for sure that are based on the research literature that's out there. So that's the first step, psychoeducation, psychological first aid. But then what? The event has happened, months, weeks, close to years have gone by. It's been a year or so now. What do you do next? There is a program that was developed in conjunction with psychological first aid called Skills for Psychological Recovery. And again, I've got a link right there in my slides for folks who are interested. They got tremendous kind of resources there for training, both for practicing clinicians and program officers to implement this or these actually programs in their places of work. Now, Skills for Psychological Recovery is focused on helping survivors continue to identify, it's kind of continuation of psychological first aid, identify the ongoing pressing needs and concerns, gathering information to guide actions now that things have settled down a little bit, acknowledge and boost any kind of strengths or adaptive coping that people have engaged in or are engaging in, empower survivors to take more active role in their recovery, teach any skills that they might not know or not be engaging in the moment to help improve their functioning, and again, continue to link them to local recovery systems, mental health services, etc., that might be needed depending on what they need. This can be done directly with kids. It can be done with caretakers. And again, the SPR, Skills for Psychological Recovery Manual, that's at that website, has a lot of really great ideas how to work with adults, with caretakers, with adolescents, with children, with specific modules specified for the age group if you're so inclined. Now, in terms of what the program entails, it involves kind of identifying current needs and concerns, and then sitting with a person to decide what are we going to address. As in psychological first aid, you're really focusing on one, maybe two things at a time. Again, folks are recovering from a really kind of significant life event. We don't want to overburden them. So we're looking at things like what does the survivor identify as the major problem area? What's causing the most serious distress or impairment? What problem seems to be antecedent to all the others or is worsening over time? If I fix this, will it fix other problems? So you're really trying to find maybe that one or two things that would have the most leverage in helping them kind of get their feet back on the ground. Ultimately, though, in just making that decision, ideally you want to pick something that is under the person's control, is something that you can change, and ideally something that can be addressed by the Skills for Psychological Recovery skills plan, and then move on to make an action plan with the folks. And I'm going to go through kind of different ways to make action plans depending on the problem in just a second, and then follow up on skills implementation with folks. And that's really all there is to psychological or Skills for Psychological Recovery, SPR. In terms of areas where you focus in terms of helping people, you focus on things like problem-solving skills, promoting positive engagement and positive reinforcing activities, managing people's emotional reactions to reminders or ongoing kind of events, promoting helpful thinking, and helping people rebuild any kind of healthy social connections, particularly in the aftermath of community disengagement. This can be done in group formats, it can be done in individual formats, and it's not really treatment, it's more about teaching. So again, we're not trying to get people to go over their feelings and get in depth into the responses. We're really just saying what's happening to you and how can we help. And again, just an extension of psychological first aid for later on. Now, I'm not going to go into a lot of detail here, but just to kind of give you a sense of what each of these core skills are. You can see for building problem-solving skills, they're really focusing on, what's the problem? How do you break it into doable chunks? Deciding who can do what, setting goals, brainstorming how to do those goals, and then trying to implement them. If you're looking at, say, promoting positive activities, the idea is that we have, our reactions to these events involve thoughts, feelings, and our behaviors. We have very little control over our thoughts and feelings. They are kind of natural reactions to the events in front of us, but we do have the ability to change our behaviors. So we're going to focus on things that give you a sense of meaning and purpose and control in your day-to-day life. So again, in these cases where people are feeling kind of disengaged or feel like they have no meaning and purpose in the aftermath of events, you would look into identifying and planning activities that would do that and schedule them into their calendar simply. Managing reactions could look at managing triggers, teaching skills to turn down the reactions or to manage their reactions, and creating plans on when and how to do this in concrete ways. Now, I'm talking about these in kind of abstract, but you can see there's a long list. I just listed them here, but there's a long list of worksheets in a workbook that you can use with patients that are fairly simplistic and make it really easy to kind of implement these things for people who are typically dysregulated. So here are two worksheets, on how to manage reactions worksheets, very simple, asking people, describe the situation, what you could do to help yourself feel better, and making plans, specific situations, and when you would try to implement it. In the other case, breathing exercise is very simple, breathing in, breathing out, diaphragmatic breathing exercises. So if you're looking at something, say, like promoting helpful thinking, which is essentially kind of basic cognitive restructuring, they have, kind of modules available to you to help folks identify unhelpful thoughts, identify helpful thoughts, rehearse helpful thoughts, and then assigning practices and ways that you might be able to rehearse this in your daily life. Here's a couple different ways that the workbook provides you resources in order to do this with folks. So people can walk out with something tangible in their hands, because if they're dysregulated, they're not likely to remember what's happened in the room with you as you would go on. Again, there are resources to help you in terms of rebuilding healthy social connections, which means finding out who's in their social network, who in their social network could be helpful, what those people on the network might be able to do for you given your needs, whether or not these are good connections. Do you have bad connections that are undermining your ability to cope? Maybe you should refocus in different relationships or in different ways with these people, and then making some kind of a plan and what to do and how to re-engage with people. And again, there are workshops for this, or not workshops, but worksheets for this. Things like how to get social support from other people, how to give social support to other people, anything that, and there's several resources here, and I'm just giving examples right now. But again, simplistic, take them home with you. Again, things that you can use in sessions with people or during these encounters with people in order to give them something concrete to work on as they walk on and move on with coping with their day-to-day life. And again, there are a number of different modules here for different kinds of problems. And again, this is all in the Skills for Psychological Recovery workbook that, again, highly recommend that folks become familiar with if you're not already, if you're interested in dealing with the aftermath of adverse life events. Now, again, if we're looking at kind of step two kind of things, one of the things we need to consider is what do we do for people that do need help? And I've already talked about universal interventions not being helpful, even if they're based on cognitive behavioral principles like restructuring or anything along those lines. But again, if people are showing symptoms, say acute stress disorder, any kind of acute problem, brief CBT, and there are several protocols out there for brief post-event CBT of 2 to 6 sessions that seem to work fairly well in preventing PTSD or reducing responsiveness to PTSD, as long as people are referred to these things based on good assessment prior to the interventions. If you're looking for a good example of a brief CBT kind of protocol that you might use with kids, there's trauma-focused cognitive behavioral therapy, and you can see here's the modules. It's available at the Medical University of South Carolina. I've got the link there at the bottom of the page that has tremendous resources and trainings available, oftentimes free trainings available for people who might be interested in implementing this in their practice or at the places that they work. But ultimately, probably one of the most important things that people can do in a step care model is watchful waiting. And again, in the immediate aftermath events, you implement, psychological first aid, maybe SPR, maybe, and refer people that need to be referred to the care that they need that's available in the moments. But ultimately, for everybody else, what you're doing is essentially waiting. You've given them what they can to cope. You don't want to interfere with people's natural ability to cope by giving them too much of attention as a clinician and essentially communicating to them that, boy, you really need help. I, as a clinician, need to intervene. But again, you need to be able to keep contact with people. So that's one of the kind of the hardest things of a step care model for grief and trauma is then waiting. But again, I want to highlight for folks that, resilience is the norm, and waiting actually probably is the best thing in many ways. Now, during this watchful waiting, having kind of some kind of programmatic way of being available to people if they're, if they experience any kind of exacerbation of symptoms. So again, part of maybe the first part of the step care model of psychoeducation is, your reactions are normal today, but if 2 or 3 months from now, or a couple of weeks from now, you continue to experience these things, here's a number, call me right away, I'll help you out. Okay. And again, at any point in time, I can't highlight it enough, suicidal ideation, suicidality is really high, so continued monitoring of that and making that an explicit kind of point of contact for folks during this waiting period would be critical. In terms of intervening in PTSD, again, follow normal treatment guidelines after 30 days. If they're still experiencing, meet criteria for PTSD, you would intervene. And the same in intervening with major depressive disorder. If people are showing the symptoms of a major depressive episode right now, precipitated by the events they just experienced, you don't need to wait. You should intervene in the ways that you would normally intervene. Okay. Now, I know folks might be familiar with the bereavement exclusion in the past. That's been removed from the current DSM if you hadn't read it. So just a heads up on that. In terms of then interventions that you might offer for folks, or you might want to make available for folks if you can, in terms of ongoing therapy for folks that do need it. There are a number of empirically supported therapies for post-traumatic stress disorder, including prolonged exposure, eye movement reprocessing and desensitization, narrative exposure therapy, written exposure therapy, or all exposure therapies, cognitive therapy. Beck's cognitive therapy has been shown to work very well. Cognitive processing therapy, which is a kind of mix of exposure therapies and cognitive therapy, has also been shown to do well, as well as just straight behavioral activation without cognitive restructuring has been accumulating some initial evidence that it works well for PTSD, though it's in initial trials at the VA right now. Now, if it's not PTSD and people need help and it's, say, more grief-related, what do you do? So in terms of, say, reactions to loss, loss of a loved one, there are a host of ways that people might react. But again, just doing a good assessment in terms of depression, anxiety, generalized anxiety, substance abuse, suicidality, and intervening based on what you find is still the rule here. One thing that you do see with people with grief that can perhaps interfere with their ability to adjust, that's not really baked into some of the other protocols, is if you've lost somebody in the consequence of events or just through bereavement, exploring with people a little bit about what the loss is evoking in them. It could be in terms of, I've been a bad child, I've been a bad mother, I've been a bad son, because I didn't do something, or did do something, or said or didn't say something. So you might want to normalize those earlier than later. It doesn't necessarily mean that you're engaging people in treatment. You're just providing them supports. You might also ask people, and when you're doing evaluations kind of early on, because you've lost this person, what role did they have in your life in terms of providing you kind of day-to-day routine and reinforcement? And are there ways that you could do that, or kind of get those kind of reinforcements, engage in a routine and substitution for those things? If the problems are relational in origin and there are unsaid things or unresolved conflicts that are eating at people that you think might then exacerbate their problems and lead to, say, prolonged grief disorder, you can kind of early on just have them maybe explore writing letters to the deceased that they, so they can say the things that they want to say. Or if they have unmet belongingness needs, kind of talk about maybe their ongoing connection with the person where they are, wherever they may be, and how they're always there and loving you, or depending on their spiritual beliefs, or exploring other ways for them to engage with others. In doing this, particularly if there are relational issues, kind of post-trauma issues with anger, feelings of detachment, feelings of being burdensome to others, would be all things that you'd want to consider rather than just send people out and start trying to engage in social supports in the context of grief. But in terms of what's out there for empirically supported therapies for prolonged grief disorder, I have to say that there really isn't a whole bunch that has a lot of empirical support at this point. The majority of treatment studies for grief suffer from either validity problems in terms of what the interventions consist of, or what the people who are in the studies are suffering from. Very often folks have PTSD and maybe not have grief, but they've been in grief studies in the past, for grief treatment studies. And of course, all of these are related to not adequately screening for grief. And for most part, most of the early research on individual psychotherapies for grief has been hampered by the fact that there's been no consensus on the symptoms of what pathological grief was until recently, which meant that many of the studies that you see on grief treatments use varying and drastically different kinds of definitions of who could be in the study themselves, leading to all sorts of different kinds of outcomes. Particularly in the early studies, grief was conceptualized as a form of trauma, and then treated as a form of PTSD. And though it's clear now that that's not necessarily the case, it's hard then to take some of these studies and use them as evidence of empirical support for any kind of interventions for individuals at this time. Only recently has there been targeted efforts to develop treatments for prolonged grief disorder in its current conceptualization. Of those, these have involved, I'm going to skip this, I've already said it. Complicated grief therapy. This was developed by Kathy Shear at Columbia University, and it involves, the treatment package has 3 parts. It involves kind of an exposure therapy to the reality of the loss of the day of the death, with cognitive restructuring about the reactions to learning about the death of the loved one. It involves modules from interpersonal therapy for depression, Myrna Weissman's work in that area for depression, focusing on navigating changes in family roles, in family systems, and then reviewing positive memories of deceased to help kind of promote an accommodation of the loss, and maintain a sense of continued bonds with the folks, even after the death. Now, other treatments that have been evaluated have been a combination of prolonged exposure and cognitive restructuring. There was a dismantling study done in which each one of these components were given separately in different orders with populations. And what they found essentially was that prolonged exposure to the events around the death itself were helpful as long as it was followed by cognitive restructuring about reactions and where people are going in their life next. Other trials have looked at cognitive therapy for grief. There's quite a few studies on cognitive therapy for just a straight old kind of Beck version of cognitive therapy for depression modified for grief. And again, it's focused on any kind of automatic thoughts related to reality of the loss, problems with orientating to the future, any kind of negative emotions. They could include kind of negative cognitions about the self, meaning fear about moving on and leaving the deceased behind, catastrophic misinterpretations of what's going to happen to me now that I don't have this person in my life, that the world is unsafe, that this random thing happened to this person means that everybody's unsafe all the time, self-blame, mistrust of others, excessive guilt or anger. And these last couple ones are particularly salient for people who experience loss. Research on how people who experience loss get social support, or what kind of social support they get, has indicated that when people turn to people in their social networks seeking social support in the aftermath of loss, they tend to get non-genuine responses that are distancing, meaning that when people turn to others in their social networks and say, "I'm so sad about what happened," most people who've experienced loss in these studies have said what people say is, "Oh, time will feel better. Let's change the subject," or something along those lines. I mean, essentially anything that keeps the person from talking because it makes people uncomfortable and they don't feel like they don't know what to do. What happens is, for most people who experience grief, and at least in my practice, have said, when I started in the aftermath of the loss of my loved one, I had one group of friends, and over time, I have now, at the end of my process, I have another group of friends. These people weren't here for me. They didn't really want to hear it. They found it to be too overwhelming. And instead, I have this group of friends. So if you're doing cognitive, any of the treatments here that we're talking about, these issues of mistrust of others, guilt or anger can also be about the people in their social networks and their reactions, something to bear in mind. The aim of cognitive restructuring for grief across all of these trials has tended to focus on things like restoring positive memories of the deceased, acknowledging or restoring caring feelings for the person when appropriate, affirming resilience and positive coping, having people retell the story of the death, just having somebody bear witness to what's happened, and what the reactions were, what the consequences were to me. Of course, working on acceptance of feelings, recognition of the significance of loss, so on and so forth. So there are a lot of different points that are really kind of amenable to straight cognitive therapy in the context of grief, and the initial results of these trials suggest that this may be something pretty useful over time. The last one I'm going to talk about today in terms of individual therapies developed for grief is just straight behavior activation. One of the things that characterizes prolonged grief disorder is a disengagement from social environments. Because I'm experiencing loss and I find no reward in other people right now because I'm focused on who I've lost in these moments, people tend to start avoiding and disengage from their social environments that lead to all the subsequent functional difficulties that are associated with prolonged grief disorder. So behavioral activation simply looks at folks and asks them the simple question, what kind of person were you before the death? What did you used to do that you don't do? What kind of person do you want to be now? Do you want to do the same things you used to? Do you want to do something different? And then how are we going to do this? How can we take that and move it into concrete things that you can do today that would change your life and provide you some kind of meaning and purpose in the context of experiencing grief in the aftermath of your loss. So this might be things like engaging in behaviors incompatible with any of the kind of symptoms that are interfering with people's day-to-day lives. It can be things to do instead of repetitive thinking, like pining away or ruminating. It can be things like addressing primary or secondary stressors associated with the loss, any of the cascading losses that come from losing a loved one. Again, just focusing on promoting connectedness, behavioral activation around that, or any kind of engagement in meaningful, identity consistent, value consistent, identity building activities. And again, if you're looking for a model for a good kind of approach to treating grief in the context of, say, large-scale adverse life events, trauma-focused cognitive behavioral therapy also integrates grief-focused components into the treatment. So if you're interested, again, I would check it out at the website at MUSC. It's, again, a really tremendous resource. There's a fair amount of research on grief group therapies. There are some that look on problem-solving skills, emotional support for parents, short-term dynamic therapy, cognitive behavioral groups for AIDS survivors with HIV, translations of all the individual therapies that I've talked. All of them have support at this time that grief is something that can be treated in both individual and at group levels. And again, group therapies are kind of the efficacy of the group therapies are contingent on the level of screening that was done. People who were screened to have problems do better. People who don't have problems or are just included universally tend not to benefit from these. In terms of support groups for grief, I will say that support groups can be very helpful in terms of sources of information, particularly people who are troubled with their primary support group and feel like other people don't understand. You go to a support group, then you have folks that do understand you, though there are some drawbacks that then people's only access to social support, if that is their only source of social support, is to maintain their illness, to maintain their disruption in order to get access to this. So it's something to consider in referring people to the support groups and providing them support later. In terms of evidence for support groups, tends to be fairly mixed. There's been very few trials looking at it over time, but for those that are out there, most support groups are open for everybody, and a lot of people get referred just because they've experienced loss, not because they've experienced any kind of problem. So again, there are times in some of these studies where people have shown worse outcomes, and I would think about it seriously before focusing on moving people on or providing these resources to people. And the last thing I just want to touch base on briefly in terms of step care approaches is inpatient treatment. If you're thinking about step care, of course, there's things here that might need access to inpatient care in terms of suicidality, homicidality, that are subsequent to the experience of these ends, but not necessarily always at the center of these reactions. So that's it. That's the step care response to grief and trauma. And with that, I'm going to stop sharing and throw the floor open.
Excellent. Thank you very much, Tony. So that was extremely informative, and now we are going to turn it over to two of our discussants to give some of their initial thoughts, reactions, and then not too many questions in the Q&A, but if we have time, we'll try to turn that over, spend some time there as well. So our first discussant, Dr. Adam Coles, is a general child and adolescent psychiatrist based on Maui for the State Department of Health Child and Adolescent Mental Health Division. He was medical director for Aipono Maui Residential Eating Disorders Treatment Center from 2018 to 2022. Before coming to Maui, he was an attending inpatient psychiatrist at Denver Health Medical Center, the Rocky Mountain Regional Tertiary Psychiatric Center. He specializes in trauma, psychodynamic, and family systems therapy. He enjoys hiking, swimming, science fiction and fantasy, art, and playing the piano. Welcome, Dr. Coles.
And thank you so much. And thank you, Dr. Popno, for your presentation. That was
I'm sorry,
excellent
Dr.
review.
Coles. I'll just do a quick introduction of Dr. Lassard as well, and then you guys can
Sure,
tag team,
absolutely.
if that's okay. Also, I'd like to introduce Dr. Kimberly Lassard, who is the temporary assignment district educational specialist for the Hawaii Department of Education, focusing on school-based behavioral health. She services the communities of Hana, Lahaina, Lanai, and Molokai. Dr. Lassard is also a licensed clinical psychologist and the clinical psychologist for the HLLM complex. In these roles, Dr. Lassard supports the implementation of key priorities related to student well-being and mental health. Welcome, Dr. Lassard, as well. So between Dr. Lassard and Dr. Coles, we don't have to, however you guys want to handle it in terms of initial reactions, comments, questions. We'd love to hear anything that you might have to add. Thank you very much.
I had some, but Dr. Lassard, happy to have you jump in as well. I was listening to your catchment area, which is, if you don't live in Maui County, having the sort of 3 islands plus Hana and so forth, it's a pretty wide kind of area to cover out here. And it's a bunch of very distinct communities. I think I had two big kind of broad reactions, or really thoughts, really not reactions, but thoughts, especially in the context of the last 6 months. And the first one is the experience of it as a community, and the communal experience of not just the fires, but the context. I'm going to keep using C words, I guess, because, and that's part of the question I posted, also, because this is a community where these fires are actually only the latest in a series of potentially traumatic events. COVID being another huge one, but also the context of about a century and a half of cultural losses, environmental destruction, loss of housing, affordable health care, and so on, a lot of cost of living insults. So it's the fires occurred in the context of a series of stressors to this community. And that's kind of the broader thing. The second big thing was being a provider and also being in the community and suffering actually from the effects of it. So like I was in the shelters and out in Lahaina while the fire was still burning up country about a mile away, and we had friends and family affected directly. So that really informed kind of the communal aspect of it, not just like serving a community where this has happened, but being in the community where this is happening. And I think the two opportunities that really brought up and really needs were modeling, self-care and stepping out and accessing, but also forming connections as members of the community, and not just sort of being like, I'm here to help you. Like, we all need help, so we're in trouble right now, and that seemed to actually be a thing that is a real strength in this community, was that when people came together strongly. And it hasn't diminished as much as the literature, which I looked into, and I may reference actually community resilience literature because it's kind of a personal thing of mine, as some other communities have been noted to around the world in different disasters. But I want to give the floor to Dr. Lassard.
Thanks, Dr. Coles. I think you're right. It's one of the thoughts that came to my mind too, is that when we're thinking about the work that we're doing in this particular community, a lot of the people that are doing the direct line of work are also people that have lost their homes. And some of them generational homes. Some of our providers have lived in Lahaina for a long time. And so trying to now also support them, I think that for the school side of it has been a big shift. We're not just supporting youth, but we're now also supporting our staff and trying to get those needs met. It's a difference for us, right? Where we've been so focused on kids for so long. And in some ways that's been the much more difficult aspect of the work that we're doing in schools right now.
I agree 100%. Yeah.
Supports for our staff. And so, yeah, it's such a thing that really has impacted the entire community. The few things that really, a few things really also stuck out to me, in terms of your referencing of kind of the universal interventions and kind of the lack of effectiveness. And yet I think in our own experience, what we found is that that is really where people have wanted to go. It's like, we have to deliver services to all of the kids, and trying to really help people pull back a little bit and maybe recognize that that may not be the most effective approach has been certainly a challenge. But I think we're getting there, but that, I think because our community is so close and connected, everyone wanted to kind of take care of everyone. And, when kids return to school, we don't need to deliver mental health services to all of our kids, but we need to support them. And so what does that look like? And what does that mean? And so I think as a complex and as the DOE, I think we're very fortunate to have Dr. Melissa Breimer from the National Childhood Traumatic Stress Network partner with us to kind of really help make sure that our staff was trained in psychological first aid right away, and do some of the work around supporting our staff with the skills for psychological recovery work, and to help kind of offer some from the outside kind of like reflective kind of listening that needed to happen so that people felt heard, but that we're also getting the supports that we needed to kids and the families. So that really resonated with me as well.
Yeah.
Thank you. I agree.
I
Go
will
ahead.
just,
Sorry, Dr.
sorry. I will say that I think something that Dr. Coles said really resonated with me is that in terms of things that you can do in the aftermath, of course, there's the skills that we talk about here and all the things related to our professional training. But I think perhaps one of the most powerful things is that community engagement that Dr. Coles was talking about. Helping people and providing opportunities for people to help each other probably is one of the best things that you could do. There is actually even research that suggests that providing help to other people in the context of coping with the same events is one of the strongest things that you can do in terms of promoting your own coping. So, as professionals and providers in our communities in which these events happen, perhaps one of the better things we can do is just be a member of the community and model community engagement. And maybe that's a way of helping the kids that we're not kind of providing service with directly. So I think that's a tremendously beautiful idea.
In this community, totally exemplified it at every level, and that includes the kids. Kids were helping each other. They were donating materials to each other. They were drawing and painting pictures for each other. I mean, it was amazing to see. And families who had no home were out delivering food and water and supplies to other people. And I think it gave them a real powerful sense of community and agency and doing something that matters. I always remember, like, one of my favorite shows had a scene where this guy's talking about his wife who always helped him come and clean his apartment. And he's like, why do you keep doing this? My apartment's filthy. She's like, yeah, but if I clean my place, I've just cleaned my place. But if I come and help you clean your place, then I've helped you and we've done it together. And it just matters more, and this community really engaged in that kind of thing wholesale. But I think the other thing that we need to sort of accept and help people really internalize is there is a kind of one-way nature to this, meaning things have changed and they will never go back to the way they were. And to normalize that, not in the sense of like this is normal or okay, but to that it is not okay, and it's okay that it's not. But even if, and I've met quite a few kids who moved, had to go to a different school for a time, and then they'd return to either their homeschool or the new homeschool, and things are not the way they were. Their relationships or social circle are different, and that's a real thing. And I sort of knew that would happen, but you don't really know until you see it and they're talking about it, and trying to sort of help people through that, and adults and families as well. I'm a family systems guy, so people exploring what is their new support system, their new activities that make them happy. And a lot of people have reinstituted, taking up music or something because they feel that sense of urgency of, wow, I just totally got reminded of my mortality. I'm going to do this thing. That's really important.
Yeah, and providing people the space and support to do those things.
Totally. Yeah. How do you guys, I think one of the things that's been concerning me is community cultural losses. So we've lost quite a few artists and musicians, not necessarily directly the event, but also in the aftermath of the loss of housing and the cost of living here. We've had a real drain on really rich cultural members of our community who have had to move to the mainland or other islands, and that I feel that very acutely, because that cultural richness is such a thing, so important to the health of the community. I don't know what to do directly about it, but I think it's something that is this follow-on effect, and I'm not sure what to do as a member of the community.
I think it's a really important issue. I mean, I think, well, from my research, I don't really look at loss as just being kind of loss as a consequence of losing a loved one, but of losing of things that are important to your sense of self. The things that make me who I am. I think you can experience loss, and we've got some data on this. Not that it matters, but that these can be as acute as losing any loved one. I think that these are as important a loss as the events themselves, and could be something to really focus on and discuss kind of with patients and broadly in communities about, where are we now? And how are we adjusting to this as well? Because this is really kind of part of the secondary kind of cascading losses that are exacerbating potentially and exacerbating people's responses and undermining people's ability to cope. So I think it's important to acknowledge these things and put them out there. So yeah, I think it's a really important insight.
Dr. Lazard and well, everyone here really. I mean, I think one of the things that we encounter a lot is what I would call appropriate anger, not pathological anger, at the event itself, at the circumstances that led to it. And without, and as a clinician, as a practitioner, I try not to get sort of into the weeds with like politics and economics and things too much, but just normalizing and recognizing people's very understandable anger. And it's something we haven't, as a therapy community, talked about a lot about. But it's coming time, and I very like the watchful waiting part, of your presentation. I thought it was, just so well taken from me, because sometimes you just have to wait for people to sort of self-present and reach out, for help in the way that they need, and be a giant ear listening for what they are asking for, But sometimes people just need to express that they're angry. I was going to use a different word, but I remember we're in a big presentation, but they're really mad. And so are we. And so also separating those and having good boundaries between our different or same emotions.
Yeah, no, I agree. I mean, in so many of these things, it's not about making things better. I mean, they're never going to be better. You're not going to miss the people, you're not going to stop missing the people that are gone. You're not going to be sad at the things you lost. It's about how do you live with them, and what do you do now? Which I think is part of the reason that kind of just things like just straight behavioral activation is focusing, okay, we're not going to tell you that your feelings are wrong, or focus on making, try to work you towards feelings that are more acceptable, because these are important feelings and they're real. And you really shouldn't, I'm using the should word here, but shouldn't have any other reactions. So what do we do now? And I think that's what makes this kind of work different, dealing with grief and trauma in general, but even highlighted when it's in the context of of large-scale disasters. So, oops,
I
a
love
little
your cat.
visitor here.
Yeah, I was just gonna say, I think that this is one of our, or also one of the huge worries of teachers as kids were coming back to schools, as we were reopening. You know, how do we respond to kind of those feelings? How do we respond to the conversations? They were really nervous about kids telling their stories. And what do they do in a classroom when you've got, 12, 15, 20 kids that are, explaining themselves and or really telling in-depth stories, and they did, and we had to really normalize that for our teachers, that this was okay, and it was okay to offer them space and to share some of that information, and also to help them to learn some of the tools of self-regulation. We really talked about, let's get those calm down corners and those self-regulatory kinds of strategies embedded into your classrooms, so that we can help kids that are expressing those more painful feelings to kind of be able to kind of self-regulate, and to know that it was a safe space. And what other options can we also offer them? So, I know we kind of talked about how those universal interventions weren't great. In some ways, we're, really then could use this as a catalyst to reinforce the importance of universal social emotional learning, right? So really embedding mindfulness practices into our classrooms on a daily basis and doing some of those things. That's been really, really important work.
Yeah, I agree. I mean, one of the questions here is about teaching self-care. And I think that can only help in the ways that you're talking about. I think the thing that's undermining about universal interventions is kind of the inherent message that you're here because there's something wrong with you, right? There's something going to be wrong with you. And I think that's the thing that's problematic. But things like, teaching broadly self-care, emotional regulation skills, because that's the thing that we need to teach, and it's for everybody, can only be helpful in the long run. So, yeah.
Yeah, I agree, Dr. Lassard, completely, because it gives people that foundation of communication and empathy, sort of knowledgeable empathizing for kids, and allows people to sort of feel the feels without falling back on kind of, well, it's not okay to cry, or to kind of express your feelings in that group. I can't imagine what teachers have been encountering. You know, it's hard enough for me with one family, in a room, or one child. I mean, to have 30, but I think in the last 3-4 months, kids have been amazing me at their ability to sort of engage in their own narrative process. And I'm actually a pretty big fan of a slightly different narrative therapy model than kind of the exposure, but really narrative reprocessing. Um, uh, and this little girl had already painted a picture of Lahaina like a year ago, and she went and painted over it. With like black and brown, and basically obliterated the town of Lahaina, but left the rainbow. And she brought it to her evaluation with me, and it was it was just a moment to really not say anything, but just to sort of be there with it. I was like, well, okay, you're teaching me a way to do this. And so I think those modes that we think of sometimes that are effective for kids could be effective also for others, like art and movement therapy and things like that. And I also see regression, and it's not necessarily pathologic regression, but kids move back a little bit to a mode of behavior and thinking that comes from a safer place and time in their life. And I would only really worry about that if it went on, right? If it wasn't kind of a situation where they could sort of heal and then come back to their trajectory, you know, but we're definitely seeing some of that.
Yeah, I mean, I think we've seen tremendous resilience in our students and our kids. But absolutely, and I think we saw regression after COVID too, when kids returned to school. The way of being just wasn't as clear as it was prior to that. And so now, as you mentioned earlier, you layer this on top of that. And it becomes really challenging. And I think that, oh gosh, there's so much that's happening in schools. It's actually really nice to kind of hear what your presentation was in terms of this stepped approach, because I feel like we're doing a pretty good job in terms of the amount of things that we're really embedding in schools, using the psychological first aid and training in CBITS, the cognitive behavioral intervention for trauma in school, and bounce back for the younger students. Now it's really a matter of really fully rolling out all of that work, and then the partnership that we've had, certainly with DOH and CAMD, and preparing to refer kids to now TFCBT that may need it. It's, there's a lot of good stuff happening community-wise. And I want to really honor that. As Dr. Cole said earlier, the community has really come together.
We'll just say for those in the school system, I think in some ways you guys are doing some of the best work, just by providing education, by having kids come back and do the things that they used to do, and follow the school rules and engage in the classroom in the way that they know how is probably in itself one of the more important things that you provide in the midst of all the good things that you're providing as well. So, yeah.
Absolutely. I want to appreciate the folks in the chat. I hope folks get a chance to look through it, offering what they do, their resources. And the schools are so key. I think it was after Fukushima, very intelligently, they built the core, like, new communities around schools. They were like the center of this onion, that was built out, which I thought was a really good model, because they are the center, really, of a community. And the children and adolescents support each other. Like, so many of the high schoolers from the other high schools knew, like, athletes and fellow students in STEM and stuff at Lahaina Luna, and reached out to them and brought them to their home, to stay. And it was an amazing thing to watch.
All right. Thank you, everybody. It's such a productive conversation. I feel guilty or bad bringing this up, but we're a little bit over time. I want to be respectful of everyone's time here today, and wanted to express our deepest gratitude and appreciation to everyone here today. Tony, Adam, Kimberly, Jamie, Kurt, Camdy, for hosting all the CEU stuff with HPA. So many things behind the scenes to make this happen. Our EBS committee assistant, Tristan, none of this would be possible without her, and all of you. Just wanted to express our deepest gratitude and appreciation for that. Yeah, and then one last friendly reminder: CEUs, fill out the survey. Please fill out the survey. We can't give you CEUs unless you fill out the survey. I think that's it. So that adjourns us for today. And thank you all. Have a nice day. Bye-bye.
Thank you so much.
That was great. Thank you guys for presenting.
Yeah, I just wanted to say thank you. The presentation and the panelist discussion afterward was excellent. So
Thank you.
Yeah, thank you,
Thank you.
everybody. Appreciate the chance to come talk.
Yeah.
All right. See everybody there. Have a nice day. Bye-bye.
Thanks. Take care, everyone. Bye.